Yes. All right. Can you hear me? I'd like to see some thumbs up. Anybody's? Very good. I see smiles and thumbs ups. Thank you. Thank you. So good morning. It is 9 o'clock. Time to get started. I would like to thank you for joining us today for the 6th annual Women in Data Science at Lane Medical Library Conference. Welcome. My name is Boglarka Huddleston. I am the Manager of Research and Instruction here at Lane Medical Library. I would like to kick off today's event with a short video. It's about a minute long from our Women in Data Science partners. And fingers crossed, the sound will work. Wonderful. And now that we are all excited, I would like to go over a few housekeeping items. During the presentations and the panel discussions, there is a Q&A box at the bottom of your screen, so you can ask questions throughout the entire conference. If there is a question in the Q&A box that you would like answered, please use the like button right next to it, and you can upvote the questions. During the Q&As, we will ask questions to our speakers based on the question ranking in the Q&A box. Live captioning is available for the duration of the conference. Just click the CC icon at the bottom of your screen to view the captions. I very quickly want to go over the agenda. Oops, not start the video again. All right. The agenda should be on your screen. We will begin with our opening remarks by Colleen Cuddy, who is the Director of Research and Academic Collaboration here at Lane Library. Then Ms. Eileen Koski will deliver our opening keynote. After her talk, we will have a 5-minute break. When we return from the break, we will meet our 4 panelists. And the panel discussion will be around artificial intelligence and health equity. I will moderate the discussion using the audience questions in the Q&A box. Then we'll have another 5-minute break and wrap up the conference with Dr. Rubina Rizvi's closing keynote address. The conference is being recorded, so if you need to step away at any time, you'll receive the recording via email once the event concludes. As a gentle reminder, Lane Library is dedicated to providing a welcoming space for everyone, regardless of their gender identity and expression, age, sexual orientation, disability, body and physical appearance, ethnicity, religion, or work experience. While engaging in our events and conferences, please keep in mind that we are all sharing and learning, and everyone has something to offer. Please make space for everyone to contribute. If you experience or witness behavior that is counter to any of the above or have any other concerns, please contact the organizer. You can see my name and email address there. Organizers reserve the right to remove individuals who are exhibiting behavior counter to any of the above. And after those stern words, I would like to thank the planning committee for their tireless work and dedication in the last several months to ensure that this event is a success and that we can continue putting this event up in the future. So Colleen, Amanda, Sam, Connie, and Mindy, thank you so much, and you're greatly appreciated. And now I would like to introduce Dr. Colleen Cuddy, who is the Director of Research and Academic Collaboration here at Lane Medical Library. Welcome, Colleen.
Thanks, Bogie. I'm really happy to be here, and I'm going to start us off with Lane's land acknowledgement statement. Stanford and Lane Library is situated in Palo Alto, which is within Santa Clara County. However, these are fairly recent political boundaries. The entire Bay Area and surrounding Northern California region has played an integral part in the lives of Native people for thousands of years. It has been the ancestral home to Miwok, Pomo, Wapo, Ohlone, Patwin, and many other Native people with their long histories of movement and interaction. In addition, the Spanish colonial missions and the U.S. Bureau of Indian Affairs forced many thousands of other Native peoples from outside the Bay Area to relocate here. Their descendants have remained for generations. And as a result, the Bay Area has been a rich and complex site of Native life. As a medical library, we recognize the substantial traditions and innovations in medical practice that have existed in Native communities across the Americas, including indigenous technologies for pain management, reproductive health, and other forms of care, as well as the ongoing role of the Stanford American Indigenous Medical Students organizations here at Stanford Medicine. So with that, I will kick the conference officially open and welcome you. Welcome. I am so super excited that to be here and welcome you for the 6th time. This is at Lane Library's 6th annual WIDS Symposium, and it's really hard to believe that we've been hosting this event for so many years, and they've all been amazing. This year, our theme is artificial intelligence and health equity, which really couldn't be more timely. We've gathered together some incredible women data scientists who use AI with a health equity lens to share their research and experiences with you today. AI and health equity is an important and very expansive theme. It was just over a year ago in March 2023 that OpenAI introduced ChatGPT-4, spurring a wave of generative AI use and similar generative AI services. While data scientists have long used machine learning models, and the ability to train large language models brings with it multiple challenges and opportunities in addressing health equity, whether through creating health data sets that represent all members of our population, and in our use of data sets and in the training of AI so as not to introduce bias into the outcomes. AI has huge potential to help mitigate health inequities, but only if done well. Last week, I was at the NIH at a Bridge to AI scientific meeting where a group of 4 multi-system, multi-institutional, interdisciplinary teams that are exploring 4 grand challenges in health and AI. We're generating a new flagship biomedical and behavioral data sets that are ethically sourced, trustworthy, well-defined, and accessible. And that's our goal. We're also developing software and standards to unify data across multiple data sources and across data types and creating tools to accelerate the creation of fair and ethically sourced data sets. Sounds easy, right? Obviously, it's not. And that's why we have this group gathered today. We all want data to be as open as possible, but we are struck by the need to protect the people behind the data. And when we consider the capabilities of AI and what that protection looks like is quite different than the environment that we're currently working in. If we think about HIPAA, it's 20 years old. It did not see this future of AI. Importantly, I think we are thinking through ethical principles of generating and providing access to health data sets. It's a bit of a paradox to make data open, but not re-identifiable. And it's challenging to develop an informed consent in an ever-evolving AI data landscape. In creating data sets, we need to be vigilant not to bake in bias. And we need to create ethically sourced, inclusive data sets that respect the individuals who have donated their data. We also need to encourage those who use data and are data scientists to do so ethically. And I believe we all are, and we'll hear more about that today, I'm sure, in order to advance health equity rather than cause greater health inequity for already vulnerable populations. Throughout the course of this morning, we'll have the privilege of hearing from an exceptional lineup of speakers representing diverse perspectives and domains within data science and health equity. We have curated a program that promises to inspire, educate, and spark meaningful conversations. As we delve into the sessions ahead, I encourage you to actively engage with our speakers and fellow participants. Share your thoughts, ask questions, and be open to new ideas and perspectives. Remember, it's through collaboration and dialogue that we truly propel the field of data science forward. Before I conclude, I also want to extend my gratitude to the team at Lane Library who have organized this event, including Sam Willerat, Connie Wong, Amanda Woodward, Mindy Chang, and most important, Boglarka Huddleston, who will be our facilitator of today's event. It's a privilege to celebrate the achievements of women in data science, and I hope that this seminar will foster meaningful connections today. And with that, I will hand it over to Bogi.
Thank you so much, Colleen. I appreciate those words. And now it is time for me to introduce, and I am honored to introduce our opening keynote speaker, Ms. Eileen Koski. Ms. Koski is the Program Director for Health Data and Insights in the Healthcare and Life Sciences Division at IBM Research. She has a master's degree of philosophy in socio-medical sciences from Columbia University and has worked in medical informatics throughout her career, both in academic and commercial settings, and fields as diverse as oncology, cardiology, public health, infectious disease, and laboratory medicine. Her responsibilities have included population health, data mining, data visualization, GIS, graphical laboratory report design, biosurveillance and pandemic preparedness, clinical trials, enterprise data governance, and more recently, the application of AI and other medicine learning techniques to address a range of challenges in healthcare and medical research. In addition to publications and presentations at scientific meetings, Ms. Koski has represented various organizations over the years as a participant in numerous government initiatives, task forces, committees, panels, and working groups as an recognized subject matter expert. Ms. Koski has also been deeply involved with the American Medical Informatics Association for many years, including her current role as co-chair of the Public Policy Committee and vice chair of the 2024 Informatics Summit and AI Evaluation Showcase. Her most recent work has focused on AI applications in healthcare, diversity, equity, and inclusion, and policies and best practices intended to foster innovation while ensuring safe, responsible, and equitable use of AI in healthcare. She is here with us today to give a keynote address titled Responsible AI in Healthcare in the Age of Generative AI. Thank you, Ms. Koski, and please take it away.
Thank you very much. I'm very happy to be here. Let me just get my slides open. Give me, excuse me, one sec. Whoops, let me share screen first. Okay, can everybody see the slides?
Yes, we can see you and hear you.
Okay, great. Thank you very much. And thank you very much for your introduction. And I am so happy to be here today. I'm going to mention just a few things about my journey to this field and this topic, and a little bit about medical informatics, because I'm not sure how much experience some of the listeners today have with that particular field. I know that this is focused on healthcare, but informatics is, a particular discipline within that. And then I'm going to focus on the background to AI in healthcare, what the need is, what the promise was, where we stand, and the challenges and risks. And then where do we go from here? In particular, talking about what we mean by responsible AI and describing some of the current efforts that are going on. So when I don't normally talk much about myself when I give a talk, but when I saw the topic of this particular meeting, and the fact that this is about women in data science, I really wanted to mention a couple of things, and partly they're germane to some of what my message is, because I started out in the fine arts and performing arts, and then ended up getting graduate degrees in anthropology and public health in a field called socio-medical sciences. But I was, because I was working full time throughout school, and I ended up working in medical informatics while I was in graduate school. And I realized what an exciting career it was. At the time, it was very, very new. There were only a handful of degree granting programs, and I think they were all master's level programs. I don't think there was anything at the doctoral level. But it was very exciting, and it was a chance to do something really innovative. And one of the other things that made me so happy about being invited to this meeting is that when I started working in this field, which was actually in 1978, there were very, very few women involved in technology. And typically when I would attend a meeting, I was one of only a handful of women there, at least in, in any sort of technical capacity. And so to come to a place where I see a huge number of women who are participating at both a technical level and a leadership level is very, very exciting and gratifying to me. So I'm just really, really happy to see that growth. And then the other thing is you will see a change in my own perspective, because in the early phases of my career, I was building systems and designing very practical applications. And at this point in my career and across different disciplines, I am much more interested in the societal impact of these tools and how we can address some of that by policy efforts. And as you can see here, I'm not going to go into a lot of detail here, but as was mentioned, I've worked in academia. I've also worked in industry and a little bit of back and forth. But in the early years, it was much more focused on technical things, and some of the systems were very primitive. I worked on an early system, very early Unix system. We had an editor called ED that only a real nerd could love. And when you tried to build a database, the databases we were using, you had a maximum tuple size of 49 bytes. And if you joined 3 tables, your computer crashed. So things are so much richer today in terms of the technology. And yet, even with those limitations, we did some amazing things with the team at Columbia University. We literally had a graphical medical record system that allowed you to look at the entire time course of a patient's disease. And we had voice simulated reporting for the labs that were not open 24 hours a day. We had a great deal of different kinds of functionality that was available to people. And then as I moved through, worked in different areas, syndromic surveillance was after the anthrax attacks and the fears of bird flu were very, very important. And that was at that point, we began to see some of the start of the AI tools, some early NLP work. But now, as I said, I've come to the point where I'm much more interested in the issues related not to just to developing and using the tools hands-on, but what do they mean? And how do we make sure that they're used appropriately and they don't that they actually help people and that they don't cause other kinds of unintended harm. And so I mentioned that I'm going to just briefly touch on what the field of medical informatics is. And I think this is really important because in one way, it simply combines clinical and technical people together to look at the overlap between healthcare and computers. But the reality is this is a huge community and it involves many, many different stakeholders and disciplines. And that's something that I'm going to come back to repeatedly because I think that's going to be the key to responsible AI is that kind of broad stakeholder engagement. And the American Medical Informatics Association that I've been very deeply involved with is the leading professional association in the field. And there certainly are others. There's the International Medical Informatics Association, AHIMA, HIMSS, others that people have heard of. But AMIA is the organization that has the more academic and more leadership approach to the field, as opposed to some of the others either deal with a particular constituency or they're focusing more on the technical aspects. And AMIA is really the organization that's focusing on the impact of these tools, in my experience. So what is artificial intelligence? I think we all kind of think we know at this point. So it's a computer system that can learn, can make decisions based on its own experience. And in healthcare, of course, decisions are recommendations, risk predictions, findings. It's just the various artifacts of everything that we do. But one of the things that's important is that AI can actually enable data-driven discovery, because in the past, scientific discovery, a lot of it was driven by insight, and we didn't necessarily have a lot of data, whereas now we can start to take a different kind of advantage of all this data that has been accumulated. And why do we need AI in healthcare? And I think, there are just so many reasons. There's still, we want to advance medical science. We want to reduce errors and address other shortcomings, manage data, address health equity issues, reduce clinical documentation burden. Privacy is critical. It's actually something we need to figure out how to do better, and then empower patients and give them access to user-appropriate documentation for patients and caregivers, not just, give them access to their chart, but give them access to information in a way that's really useful for them. And I'm going to touch on just a couple of these in a little bit more detail. I mean, we all know issues about data quality of care have been around for quite some time, some major publications from IOM. And we also know that costs are continuing to spiral out of control. And we know that there are many challenges to many people receiving care. And in fact, in many cases, particularly in rural parts of the country, some of those challenges are getting worse. And in marginalized community, they're getting worse. They're not getting better. And information overload is another huge problem. I remember when I first started in working in healthcare, I was actually abstracting a chart to put into the graphical system I mentioned, and you could look at a 2-week hospital stay and have 4 pages of data, which included maybe 3 laboratory values. Now you go into the hospital for a minor outpatient procedure and reams of data are generated. So the amount of data has just expanded exponentially. And plus the data itself is deeper and more complex. It's not a simple lab value. It's an MRI that has all kinds of different pieces of information embedded within it. And on top of that, we have an aging population and increasing numbers of people with multiple comorbidities and very complex treatment regimens, and which makes it much more likely that you're going to deal with interaction effects of the different disease states and the different treatments, as well as the treatments with each other. So we have a very complicated situation today. And in terms of scientific literature, I mean, these are sort of eye-popping statistics. There are over 1 million new citations in Medline every year. And the annual number of citations increased over 70% in the last less than 20 years. That's incredible. There was a study in 2004 that estimated it would take almost 630 hours a month for a clinician to keep up with the new literature just in a single field. Today, that it would take more hours than there are in a month. And so clearly that is not sustainable in terms of people being able to utilize that information. And although I didn't include it in the slide deck, one of the projects that we recently did here at IBM in conjunction with Cleveland Clinic was to work on just that and to try to show how we could apply some of the AI techniques to help them sift through the literature and do a better job of finding the things that they were looking for so that they could focus on the most important material, because nobody can keep on top of all of it. And obviously the hope is, this is motherhood and apple pie, will accelerate research and discovery, will reduce disparities, improve quality and efficiency, finally deliver on, the much touted and long awaited precision medicine, better understand what's actually going on, empower patients, and fraud detection is an enormous issue, particularly with generative AI. And so obviously the vision is that AI will empower both patients and healthcare professionals. but and it's been around for a while. I mean, and this was already mentioned, but the building blocks, I mean, I was working with NLP more than, well, maybe not more than, but 20 years ago anyway. And so many of these tools have been around for a while, and they've already been applied quite extensively. I'm not going to get into any of them really individually. There are many, many different applications: clinical decision support, adaptive CDS, image analysis. That's been one of the great success stories in AI, actually improving the accuracy and efficiency of image analysis for things like retinal scans. Syndromic surveillance that very much relies on big data and looking for anomaly detection in a vast quantity of very complicated data. Post-market surveillance, and more recently, clinical trial simulation, enrichment, and the development of novel outcome measures. So all of this is actually happening. And although I'm not going to go into this in much detail, this is just a couple of slides from, to show how we have worked here at IBM Research, taking, as you can see, all these different kinds of sources of data that we acquire on a population level, and then find a way to apply them to making a prediction that can be germane for a decision for and about a single patient. And again, this is really just kind of maybe putting the technical steps in a little more detail here. And this is an example of something we actually did. Again, this is very real. This is work we did along with JDRF, as well as 5 clinical research sites in 4 different countries, who we had over 30 years worth of data that we integrated from those sites. And what we were able to do was actually find a way, through looking at this very complex data. I don't know how many people might know much about the autoantibodies that are related to type 1 diabetes, but it's a very complicated story because people can develop them and lose them and have multiples and singles, and it's really very complicated. And so that was the data that we analyzed, and we discovered that we could accurately predict or identify patients who were going to progress. And this was longitudinal data on patients at risk of type 1 diabetes. And we could predict people likely to progress within 2 years versus 4 years versus 10 years. And this work is continuing, and we're actually have published screening recommendations based on this work. So there are very practical, real applications. And so even though I'm going to start talking now about the challenges and the problems and some of the things we have to worry about, we need to remain excited about what this technology can bring to help people. So some of the major challenges, of course, explainability and transparency, detecting and mitigating bias, evaluation of these tools, implementation and monitoring, regulation, and in particular, trust. Because right now, there's a huge lack of trust in all areas of our society. We don't trust each other anymore, and AI is particularly scary. And so winning and maintaining people's trust is a big, big challenge. The fact that some AI systems are black box systems has been a big barrier to people's acceptance for a long time, and it's understandable. And I know that much of the work that we have done at IBM, we've tried to make sure we have explanations, and so we're not saying just, oh, here's our answer, but really detail, how did we get there? What was the process, and why do we think that's right? But also make sure you work with subject matter experts so that they are the ones who are making the decisions about, does this matter? And then the documentation is a big issue when we talk about AI systems, because you really need to understand, and the data sets, and I'm going to talk a little bit more about data as we go along, but how were these systems built? How were they trained? How do they actually function? Very important, how concepts were operationalized. Oftentimes, you have a question you want to ask that has not been measured directly. So you look at data that's available and you say, what can I use as a proxy? that will give me an answer to this question that I have, because you cannot measure the thing you really want to. And that's what often gets people into trouble when they're building AI systems. And then what were the characteristics and how were these training and data sets validated? Because often there's very little documentation. You're lucky if you get a data dictionary in many cases, and that doesn't tell you much about the variability that's within the data. And then, of course, the generalizability or limitations of the system. If you develop a system on one population for one problem, can you port that elsewhere? Are the populations comparable enough that you'll have the same circumstances? How does it port to a different disease? These are big questions. And in particular, bias. We started, many of the speakers so far have talked about the issues with equity in our society. And when we're working in AI in particular, we have to always remember that we know there are systemic biases in our society, and they are reflected in the healthcare data that we look at and analyze it. And they're reflected in both the underlying health of people and in barriers to accessing care that show up as differential outcomes. And so a couple of ways that happens is there's certainly historically the gold standard for advancing medical research have been clinical trials. And there has been historically a tremendous underrepresentation of marginalized groups, and that's still true today. And much of that, there's recruiting bias. There are fears of research that are very legitimate based on things that have happened historically. There are also logistical impediments, inadequate transportation, lack of paid sick time. If somebody has, if the research site is far away, or if they have to take time off during the day, for many people, that's not an option, because if they don't show up for their job, they're not going to get paid. So there are real barriers. And also in real world electronic health records, there are also barriers because of either not having any insurance or having inadequate insurance, urban and rural access limitations. There's been a lot of issues with hospital consolidations that leave people often having to travel further for certain kinds of care, and a variety of other logistical impediments. And in addition to underrepresentation, there's skewed representation, because when people have limited access, they only use healthcare when they absolutely have to. So you may see a skewed picture of more severe disease and less ability to get an idea of how things progress from earlier stages, because people can't afford to go until they're so sick they have to. And so that all of this leads to pictures that really don't help you understand either when you could intervene sooner or how to help people. There are also differences in diagnostic and treatment recommendations historically based on race, gender, disability, and other attributes. I know I worked in cardiology for many years, and historically, if a man showed up in the emergency room with chest pain, he was up in the cath lab in 20 minutes. If a woman showed up with chest pain, she was given Valium, sent home, and told to relax. And this is not a joke. And it's not, we've come a long way from there, but these things still persist in many ways and with different populations. And then environmental factors. There are direct and indirect environmental impacts from pollution, from overcrowding, from substandard housing, and also from an information perspective, often from lack of internet access. So there are lots of barriers to people being able to participate, and us understanding when we look at data and use AI, where those barriers affected what we're seeing and what we're looking at. And so we know that algorithmic bias can exacerbate existing inequities in healthcare. If we build models based on non-representative data, we make the wrong conclusions. And if we only implement these tools in wealthier communities, we also continue to increase the digital divide by making healthcare even better for some people and leaving it behind for other people. So there are lots of challenges here. And beyond that, of course, there's just the increased costs. The cost of running large language models is not small, and the computers that you need to do this. And so, you really have to think about where the cost benefit analysis of where are the appropriate places, ways to introduce these tools. You can also come to erroneous conclusions. I'll talk a little more about a couple of examples of those and have adverse consequences as a result. And erosion of trust is a big issue. I know there was a case just last year, I think it was, where there was a chatbot that was available for patients with eating disorders, and a system upgrade went through, and suddenly the chatbot was directing people to dieting sites. And so it was the last thing that people with eating disorders needed to see, was what was presented to them because of a system change where people weren't paying enough attention to the validation. And we've already seen examples where generative AI is being used to contribute to fraud by creating patients that aren't real in order to defraud Medicare. So what happened last year? We had, I think of it as the Big Bang. Suddenly, so all of this stuff has been going on for years and years and years. And yeah, people have been thinking about it, but nobody seemed to really care until last year. Suddenly everybody cares about AI, and everybody's thinking about AI. And so finally, this seems real to people. And I think I'm going a little bit slow, so I'm going to try to speed up and get to some of the meat of what I want to talk about. And so, which is the work that's being done to really look at responsible AI and how we implement these tools in a way that increases the benefit for everybody. And I've already touched on a couple of these things. All right, and so stakeholder engagement. So how do we actually do this? At the design level, the stakeholder engagement is really, really important. And looking at your data, understanding your data, making sure it's representative, and trying to get it documented and to understand the limitations. And so, as I said, I'm going to talk a little bit about data because it's the root, it's basically, it's the substrate for AI. And so what's the problem? So it reflects real medicine, encompasses broad and rich data sites, but the data's not well documented. And the big problems occur when people look at this and think they completely understand it, and so that they build a system based on data that they only completely understand. And very interesting to look at this and think about how data is used when we work with real world data versus clinical trials. When we did a clinical trial, you formulate a hypothesis, and then you go about actually creating the data that you need to answer that question by doing an interventions with a group of patients and then following them and collecting data on them. So you actually create the data that you needed in sufficient quantity and statistical power to answer your question. When you work with real world data, you have a hypothesis, but then the question is, what data is out there that might answer this? And since, as I mentioned before, you often want to evaluate something that's not actually clearly in your data. So you have to look for a proxy or a way to operationalize that concept. And that's often where things fall apart, because people don't recognize the difference in some cases between what they see and what is actually being measured. And certainly the work of Ziad Obermeyer, is an excellent example of that, where people assumed, oh, if your costs are higher, you must be sicker, forgetting that your costs are higher if you can afford to have, if your costs are higher for sicker patients if they can afford to get the care they need, but you have many sicker patients who aren't getting the care that they need, and so their costs are lower. And if you just look at costs, they look like they're not as sick, and in fact they may be sicker. So that was, one of the wake-up calls for people about what can go wrong when you look at this data with the wrong lens and haven't brought the right people in. And so obviously, this happens at every stage, at the design phase, during implementation, and very critically in evaluation of the tool, and when you want to try to port it to someplace else. And there are both long-term and short-term solutions that you have to look at. Obviously, long-term, you'd like to enable people to be better represented, but in the meantime, there are lots of tools and techniques to do bias mitigation and understand how you can make the representation appear better. These are some of the current initiatives, and one of the things that I'm there, and there are many others. This is just a selection. So we published a very detailed set of principles through AMIA, through the Public Policy Committee. The National Institute of Medicine is just recently developed an AI code of conduct, principles and commitments that they're looking for comment on. ONC has done work on algorithmic transparency. There's a very large ongoing initiative between AMIA and the Department of Clinical Informatics at Harvard's Medical School, looking at various issues related to clinical decision support, to patient engagement, and to real-world data and evidence. The Coalition for Health AI is putting together guidelines. And there's also an AMIA evaluation showcase where every year across the 3 major AMIA meetings, we bring people in to showcase AI projects at different stages to show how they're addressing these challenges. So these are all some of the initiatives that are going on now. And these are some of the this is what I think of as the critical practical things that we need to do right now. Establish these communities of practice and assure this broad stakeholder engagement, have public and private partnerships, commit absolutely to have the patient voice and perspective at all times, because we have to remember that at the end of the day, they're the target of all of this AI, one way or another, whether we've developed a new drug or a new treatment plan. It's the patient. The whole goal is to improve healthcare, which means the patient is the target, and the recipient or other of this, we have to continue to work with the principles, codes of conduct, guidelines. Training materials are so important. How do we help people to understand from a technical or a clinical or a patient perspective, what are the questions they should be asking? If you don't know what you should be asking, you're not asking the questions for sure. And so we want to start to develop training materials aimed at different audiences with different perspectives, potentially something that called nutrition labels for algorithms and tools, so that people can look and say, okay, these are the characteristics. This is how it was created, how it was trained. This is exactly what it's supposed to do. This is where it was certified, in what population, for what disease, for what use, and hopefully start with voluntary certification. And so basically, I know that was a lot of information, but my hope is that we can address these challenges. AI can raise the quality of healthcare for all, and as well as addressing some of the critical issues that are happening with the workforce, in particular clinicians who are becoming, both nurses and physicians and others who are really burned out by documentation burden and other issues. However, we have to address the risk of these disparities and the misuse, and we have to make sure that we keep the stakeholders across a very large team engaged. So thank you. And with that, we have any questions?
Thank you so much, Eileen. That was a wonderful and very thoughtful and informative presentation. Yes, we do have 2 questions. The first one is, I have seen a lot of proposed frameworks for ethical AI, and I believe that many academic medical centers are likely to adopt them. But what of the public sector? Are you aware of any policy initiatives to help regulate for-profit companies which may be less interested in ethics and more motivated by profit?
There are some. We have brought into this AI, this FAMIA DCI coalition. We have a number of for-profit companies involved, and I can speak certainly for IBM. You know, we have a large group doing ethics, and we have our own guidelines for what constitutes responsible AI. And one of the hallmarks of our work is that we always engage very, very closely with the expected end users of the systems. I know that it's a little bit, I can't speak for too many other companies, but I do know that some of these efforts are looking at focusing on guidelines that would have more teeth and would apply to more organizations, but it's not easy.
Very good, thank you. There's another question. How do you clean a biased data set so that it would produce more accurate results based on the research question? Can you eliminate bias from existing data sets?
You can't completely eliminate the bias if it's there, but there actually are a number of tools. And as I said earlier, I'm not that hands-on anymore, but there are some tools that are used that have to do with how you sample, potentially oversampling population subsets that may not be adequately represented. There are tools to, randomly select people. There are a variety of tools related to sampling, as well as looking at ways to combine data sets to help enrich them. That's one of the things, as I mentioned with the JDRF project, why we had several different countries involved with this, because you had very different populations in these 5 different sites, and you wanted to, and we knew that nobody was going to have the whole picture. But when you manage to put a lot of that together, okay, now you can maybe have a better shot at seeing across different things. So there are, they're not always easy. And one of the challenges, of course, is now there's a lot of data just out there, and people are not taking that kind of care and attention when they're analyzing it, because they don't necessarily understand what's at risk. And they think, oh, it's just data. Data is data, and my tool can handle all the data. But it's a big challenge. And I know that there are Ziad Obermeyer has an organization that's doing a great deal. There are a number of sites. I can send some links along, sites that are really focusing on addressing injustice and access and representation in various ways. So I know that there's a lot of activity happening, but it's going to take some time before, and if we really want to control some of the big technical aspects of it, at some point there's going to have to be regulation and other kinds of requirements. There's no way around that. We'd like to start with more voluntary certification criteria, because we don't think we know enough to do a proper regulation yet, quite frankly. We think we need the experience of trying to develop these voluntary certifications and standards and see how they work before we can say, okay, this is now how we can regulate it. And we can now reasonably require this of people, but we're not there yet.
Yes, I agree. Thank you. Another question. Do you have any insights on the OMB revisions on standards for maintaining, collecting, and presenting federal data on race and ethnicity?
We're actually working on that with FAMIA right now. So, we have put together a team that's reviewing their recommendations and coming up with a response. And I have not been directly involved with it, but there is an active team that's associated with the Public Policy Committee, and they'll be bringing back the recommendations to the larger policy committee to review once they finish their first pass at addressing that. So that is, and we definitely have a lot of comments, and I'm happy to say, for example, a couple of weeks ago, we actually met with a number of Hill staffers talking about some issues, and they were very receptive to our message, because they understand that this is, as I said, it's a big tent, it's a very broad community, and they understand that there's a lot of good information we can give them about what is and isn't possible and what needs to be done from a perspective of people who understand how things are being done.
Very good, thank you. Next question, we have 2 more questions, and that probably will take us to the end of the presentation. So you seem optimistic about the potential AI, I'm sorry, one more time. You seem optimistic about the potential AI has for impacting healthcare. What kind of government regulations do you feel are necessary to getting us to an increased place of trust with AI as an effective tool?
Well, I think a lot of that goes to requirements for the types of evaluations that I've talked about, both evaluations of how people train these tools, how they document them. And so that when if you can look at, because right now that really does not happen. And if you can look at documentation and clear use cases and statistics about what has happened, that can go a long way towards helping people learn to trust it and see, okay, this is how it's been applied, and this is what you do, this is how you keep evaluating it. And the evaluation has to be ongoing. If you have systems that are changing over time in response to new data or new uses, you have to constantly reevaluate. You can't just put it in and say, okay, we validated it, it's great, it works. But then you use it for 3 different diseases, or you take it from an urban medical center and take it to a small community hospital. It's not going to work the same way. So a lot of it has to do with requirements to make sure something has been validated in the context of use and in the setting of use, so that so that you're sure that when you use it in a different place at a different time for a different reason, that it is still going to work. And then if not, then you have to re-engineer it. But a lot of it is starting to agree on exactly what it is that we need to do to make sure this is safe and is going to be helpful and not actually introduce new harm.
Very good, thank you. And one last question. Wonderful talk. How can we encourage companies and groups to minimize working in silos? I find so many people working on similar problems. So much time, expertise, and money is invested, and quote unquote, nothing comes to fruition because those on the tech side are used to short runways and lose interest or faith too quickly. If groups were to work together, this might be avoided. How can this be promoted from the inside?
Well, and that's exactly what we've been trying to do. And it's interesting, even just this week, we had a suggestion from somebody within one of the groups that I've been working on to create a new task force. I'm like, no, we've already got this group. We want to build on the groups that we have. We're not going to, yes, we can have a working group that comes back to the larger team, focusing on a particular problem, like I just mentioned, about the ethnicity codes that we had. We put together a group of specific subject matter experts who really knew that topic. They go off, they do their work, then they come back to the larger group. But we are trying very hard to coordinate across all these different organizations. We're working with the government, we're working with private industry, and that's much of the role of AMIA, is to help to coordinate that across those different stakeholders and try to, because yes, of course, if everybody's just off in their silo and not doing something, you have a million Me Too initiatives going on, and they're not productive because everybody's starting from scratch. And so we need to really have more of a centralized way for people to understand where they can go to be engaged in the process and to get information.
Awesome, very good, thank you. And with this question, we actually come to the end of your presentation. I really appreciate for being so engaging and informative. At this point, we are going to take a 5-minute break, and it's 9:55 Pacific right now. So we will come back and begin our artificial intelligence and health equity panelist discussion at 10 o'clock. So we have a 5-minute break for everybody to stretch. All right, hello. Hopefully you can hear me. Welcome back from the 5-minute break. We are about to begin our artificial intelligence and health equity panel discussion. We have 4 wonderful panelists today, and I will introduce them one by one, and they will have a few minutes to talk about their work and interest in AI and health equity. Then I will facilitate the panel discussion. We do have some pre-prepared questions to get the conversation going. And if you have questions, please drop them in the Q&A box, and remember to upvote questions that you would like to hear answered during the Q&A. So with that, I would like to introduce our first panelist, Dr. Eileen Chen. Dr. Chen is an assistant professor at UC Berkeley and UCSF Computational Precision Health Program with a joint appointment in electrical engineering and computer science. She's a member of the Berkeley AI Research, BEAR. Her work centers on machine learning methods for improving clinical care and making it more equitable, as well as auditing and addressing bias in algorithmic models. Her work has been published in machine learning conferences and medical journals, and has been covered by media outlets including MIT Tech Review, NPR, WGBH, and Stat News. She has been named a rising star by the University of California, Berkeley, Harvard, and University of Maryland. Eileen received her PhD in electrical engineering and computer science from MIT, her ABSM in applied math from Harvard. Welcome, Dr. Chen.
Hi, everyone. Should I present now? Yes. Oh, great. I prepared a few short slides. I was told to do 1 minute, so we're going to do a very quick 1 minute. Some of
you can do 2 to 3.
2 to 3, so generous. Hello, everyone. Thank you for the great introduction. As mentioned, I'm joined between a lot of different departments and a lot of different institutions, but lately I've been thinking about a pressing question, which is how large language models might perpetuate bias or mitigate bias, and what the implications might be for equitable healthcare, which I believe will be of great interest to this crowd. My research in general focuses on this entire machine learning pipeline. So from the problem selection, thinking about what we work on, how we collect the data to address those problems, what outcomes or labels we decide to use as ground truth, so to speak. Then how do we develop those algorithms? And then lastly, after you deploy them, after you start using them, what kind of considerations should you take into account as they start to make high stakes decisions? Recently, thinking about large language models, I have 2 works that I'd like to spotlight very quickly today. One of them is in a case study of maternal health, which is asking the people who are most affected, what do you want from large language models? In this work, with many of my talented collaborators here, we interviewed over 100 healthcare professionals, women and birthing people, as well as medical conference attendees, to get a sense of what people want from the large language models and what kind of values they prioritize. We did both qualitative interviews, but we also did some quantitative surveying as well. So some highlights of that is that women and birthing people, above all else, when they think about LLMs, when they interact with LLMs, they really want to know that their responses and their questions will be private, and that they will retain autonomy in a healthcare system that is increasingly automated. Healthcare workers are really concerned about transparency and accountability, thinking about if they follow this large language model, who is going to be blamed ultimately, and also where did this large language model come up with these ideas? Lastly, we ran a workshop on health equity specifically, and those participants, perhaps not as a surprise, were really interested in inclusivity. How can we bring as many people to this table as possible, both in terms of discussing large language models and developing them? Another work I'd like to highlight today is thinking about how we can use large language models to understand existing clinical workflows, specifically in the case of treatment protocols. Oftentimes we prescribe people treatments and then they switch to another treatment for all kinds of reasons, and it's not often well documented in the electronic health record in structured data what's going on. Using large language models, we seek to better understand the unstructured clinical text. And one of the first things we found is that there's many different reasons in the case of contraceptives here, why people might start with one contraceptive and switch to another. You can see that there's many symptoms like irregular bleeding, or there's sort of logistical considerations like forgetting the daily pills. The thing that was of interest to us is, in fact, that you can start to uncover differences in insurance coverage and how that affects people's choices. And in fact, when we broke down these topics by patient self-reported race, we find that that topic, that insurance coverage topic, has different enrichment values, meaning it affects different races of patients differently, primarily affecting Latino, Black, and multi-race individuals. The implications here mean that we can have a better understanding of what are the clinical and non-clinical factors that can affect people's treatment protocol. So at a high level, if there's anything, I'm very much looking forward to this panel, but if I could leave 3 takeaways: people over algorithms, evaluate what's going on, ask people what's going on, and then being creative about the solutions and the challenges.
Awesome. Thank you so much, Dr. Chen. And then I would like to introduce our second panelist, Dr. Nishita Kothari. Dr. Kothari is a professor of radiology, Division of Interventional Radiology at the Stanford School of Medicine here in California. Her expertise is in interventional oncology with specific interest in endovascular and ablative therapies for liver, kidney, and bone. She has published extensively and is known nationally and internationally for her work in emerging therapies, healthcare economics, and medical ethics. She is the current medical co-director for supply chain for the Stanford hospitals. Please welcome Dr. Kothari.
Thank you so much for the warm welcome. And so far, this panel has been, this whole webinar has been super interesting. And I really want to thank the Lane folks to putting this together. I didn't realize this actually even existed till I got invited. So thank you again. Really appreciate it. And so, you know, I am the other half of Irene, if you will, in that I do not understand how to put these models together, but I am the end user, the consumer of these models as a physician. And so for us, as an introduction part of it, I actually work with ethics a lot, ethics in medicine. And one of the things that you realize as a physician is that some of the clinical trials and protocols that were put into place eons ago, and by eons, I mean, 50, 60, 80 years ago, are not necessarily representative of our patient population. As with everything that we've seen, our understanding of inclusivity and representation is still at very much an infantile stage. If you think about 80 years ago, things like ethnicity, things like socioeconomic status, things like social determinants of health were not even regarded or were not considered when a clinical trial was put in place. The biggest example I can give you is the Farmington risk for cardiac disease, which was pretty much, it was done out of North Atlantic, if you will, and actually Upper West also. And a lot of that data comes from white or Caucasian males. And as a South Asian, I'm acutely aware of that because the cardiac risk factors for South Asians are very different from Caucasians, just genetically speaking. And so it behooves us to use these new language models to understand how diseases affect different ethnicities, how social determinants play a role in healthcare delivery. And also something that's near and dear to me is how do you make healthcare more affordable so people can actually take care of the health, right? I mean, I know it sounds very altruistic, but healthcare, the way we are right now, is really the best healthcare really is based on your socioeconomic status, and that's not what you become a doctor for. So I'm hoping that we use language models, equity, and AI to deliver consistent, more inclusive healthcare. That's for me. That was a very long introduction, so I apologize.
Oh, no, you're good. Thank you so much, Dr. Kothari. Next up is our third panelist, Dr. Nicole Thomasian. Dr. Thomasian is a resident physician in anesthesiology at the Weill Cornell Medical Center at the New York Presbyterian Hospital. She holds a joint she holds a joint MD, MPP from Boston University, Warren Alpert Medical School, and the Harvard Kennedy School, respectively. She graduated with honors from Brown University with a BS in neuroscience. Prior to matriculating at the Warren Alpert Medical School, Dr. Thomasian studied neural rewiring following stroke as a Fulbright Fellow in Japan. During her time in medical school, she worked on the development on clinical AI and big data algorithms at the Brown Radiology Artificial Intelligence Lab and Lifespan Brown Center for Digital Health. Nikki's research focus is on the development, clinical integration, and regulation of artificial intelligence and digital health technologies. Please help me welcome Nikki Thomasian.
Thank you so much for the warm welcome. I am so grateful to have been invited by the Lane Library, and thank you so much for organizing this. So I'm going to share my screen now. Let's see here. Okay. All right, and hopefully everyone is able to see this. But again, my name is Nikki Thomasian. I am a second-year anesthesia resident at New York Presbyterian Hospital. As was previously mentioned, I first got started in AI research back in medical school, though I had an informal coding background prior to that. I was first focused on user experience and user interface principles, specifically as it related to emergency department utilization algorithms, and also did some mixed method research on physician perspectives surrounding this. After that, I sort of backtracked and started getting involved in the development side at a radiology lab at Brown, and we were looking at both. I helped to develop both computer vision and natural language processing algorithms for clinical diagnostics and workflow, respectively. But throughout this whole process, I really remained very interested in the implementation of these algorithms, and specifically issues around, utility, clinical utility, equity, and safety. Okay, let me see. Oh, I'm having trouble moving forward with my slides. Let's see. Okay. So obviously AI, huge issue in medicine. It's being, or huge area of medicine. It's being used for, diagnostics, therapeutics, education, all kinds of things. So it's a really important topic. And again, I've really been interested in what makes a good clinical algorithm. And so looking at how we evaluate and appraise these algorithms, given their growing abundance. And so you can see here, this is really a process that begins in the development phase and goes all the way into post-implementation, as some of the panelists have already highlighted. And so how can we entrain bias in clinical AI? And the answer is, again, at any point. And so, we need to be thinking about all of these areas. And since this is a lightning talk, I'm not going to go into all of these different ways we can entrain bias, but just wanted to hit on my top 3 practical and feasible ways we might be able to promote equitable AI right now. The first being bias evaluations. Number 1, this is acknowledging limitations in the data that we're using, both our training data as well as our validation data, making sure we have external validation, and then also looking at the model performance itself, and when applicable, conducting bias evaluation. So that means in situations where our intended clinical use case for an algorithm, where that is linked, or whatever social factor we're looking at as social determinant is linked to disparities in access, disparities in diagnostics or treatment, that we're making sure we don't, create an algorithm that's reinforcing those disparities. And so it's really important that we're looking at, different either false positives or false negatives, depending on our intended clinical use case in those underrepresented groups, and making sure we're assessing that both in the validation phase, but also in the, not only in the validation phase, but also in the post-implementation phase. Second thing being quality control. I can't emphasize this enough. There are so many algorithms that are currently being used both informally in practice, and some even as primary drivers of clinical decision-making, that are just not useful or not clinically helpful. So I think that's a big thing, and that can bias providers against use. So that's an important consideration. And third being interpretability. I think it's a really important tool that can help to promote health equity by sort of showing at the instance level what the algorithm is looking at, what it's paying attention to. So here in these slides, I shared a model that we developed. It's analyzing radiology reports. It's a natural language processing algorithm, and it's looking at cancer progression and presence. You can see two prediction instances. One is when the algorithm was correct. You can see it predicted the report as being read as stable, and that was the correct prediction. You can see highlighted what the algorithm is actually paying attention to, and you can see an attribution score, which is sort of like a surrogate for confidence. It also shows sort of a little bit almost lack of nuance in what the algorithm's looking at. That can also be important for clinicians to know as well when they're using these algorithms. The second example is a false negative. The algorithm read it as worsening when in fact this report was stable. And then also on the interpretability, on a second note, this paper we did also looked at another model of interpretability, something called BerkBiz, specific to transformer models. And this is more probably for the developers of these models. It's more useful to them to make, because it's looking at the different layers and heads and structure of the overall algorithm. But I think it's important too that we're not just looking at local interpretability, but also that global interpretability as well, to make sure that we're assessing for different levels of bias at different levels of the algorithm development. Thank you. All right, I don't know how to unshare my screen here.
There should be a red button on the bottom that says stop sharing.
Okay, let me see.
And I wonder if we may be able to.
Aha, okay, here.
Yes, thank you. All right. Thank you, Nikki.
Yep.
And first of all, I would like to remind everybody to please add your questions for the panelists in the Q&A box and upvote them if you feel like they are more important. Some are more important than others. Next up, I would like to introduce our fourth panelist, Dr. Ala Youssef. Dr. Youssef is a postdoctoral fellow at the Stanford Center for Artificial Intelligence in Medicine and Imaging. This is in the Department of Radiology. She received her Doctor of Philosophy degree in Population Health and Medical Education from the Institute of Medical Science at the University of Toronto in 2021. Her research interests lie at the intersection of artificial intelligence implementation and clinical evaluation. She works with multidisciplinary research teams to assess, design, develop, and implement person-centered AI solutions that address clinical needs. Her research addresses the ethical, organizational, and workflow barriers that impede clinical adoption of AI in healthcare. Dr. Youssef spearheads the curriculum design, development, and evaluation of several AI educational programs, focusing on creating a diverse and inclusive training environment. Through this work, she aims to build capacity for AI research and ensure the safe and responsible development and deployment of AI in healthcare. Welcome, Dr. Youssef.
Thank you so much. It's such a great pleasure to hear about all of the panelists and to be joining everyone. And thank you so much for the warm introduction. I have a few introductory slides just to give some context around the research I do, and I really look forward to the panel discussion. So it's important to recognize, again, to stress what Eileen has mentioned and what all the panelists has mentioned about bias is it's really important to know that the data needs to be fair, and representative. And one of the major challenges of why we struggle to develop equitable and responsible AI algorithms is because of the data that's being openly available for machine learning. Most of it comes from 3 states only. So 70% of the data in radiology that's publicly available to build open algorithms come from 3 institutions only, as from 3 states only. And we know that algorithms that are trained on public data sets tend to perform worse when deployed in other contexts because they have not seen this data before. And even foundation models, with all their promises, they have also shown that they're susceptible to biases in clinical diagnoses. So my research really sits at the flow of data in the health ecosystem and really looking at what are the ethical and policy regulations that ensure that AI will do no harm to patients. So to give concrete examples, one of the research projects we have looked at and was published through the Amy Center in collaboration with the Moore Foundation, was looking at organizational factors that influence organization to share data for artificial intelligence. And one of why this was important to look at is because no matter how much researchers are interested in publishing the data, if the organizations do not allow for the infrastructure and capabilities, we stay in that bottleneck problem of not being able to access data. So we wanted to understand what were the vision or what were the rationales for organizations to choose to share or not share. And what was really interesting was that organization that was able to share had alignment where sharing of data was part of their mission, and it was important to have the organizational motivation. The other aspect was organizational capabilities, which speaks a lot to health equity, because even if the organizations from underserved populations or in health community centers are interested by data, but they don't have the infrastructure, the governance, the resources, and the expertise, they wouldn't be able to be part of these data consortiums. And I really was inspired through this study to kind of see new initiative by the NIH to really build more representative data pipelines. So it's important to recognize that data is a barrier, data sharing is a barrier. And one of the quotes reads from one of our studies that there are many barriers and you can back it all the way up to the front of the line of the start of the, even start the pipeline. It's incentivizing sites to become contributors to the effort. Sorry. Even after you incentivize a site or develop a relationship with a champion at a contributing site, it's getting that person or persons to convince other people at their own home sites to become part of the process. In most cases, it's a charitable process and it's long and tedious. Even if you develop those relationships and you get those champions, you have to go through a certain amount of regulatory work locally through their compliance offices. So you can, this code kind of illustrates the barriers at the regulatory level, the barriers and lack of incentives for researchers and people who are motivated to push data for equitable algorithms development to really keep this effort ongoing. Another study I wanted to shed light on was conducting an ethical investigation of how actually clinical trials investigators of AI interventions assess and identify ethical issues that might arise in the design and conduct of their clinical trial. So as Eileen has mentioned earlier on, many of the patients who really are underserved do not present to healthcare. And this presents a number of ethical problems in terms of how are these patients selected for clinical trials? How are the algorithms validated on the different subgroups? Do we know do we really provide an informed consent for patients with different health literacy and backgrounds to really understand what are the risks and benefits of the AI intervention? So you can, if you scan this QR code, you can see a link to the full poster, but this is just a brief overshot of like what I really do. And I think if there has been 5 key takeaways, I think it's number 1 is trust building. And so there is a need for trust building. There's a need to think of what incentives we have in the system for us all to work towards health equity and AI. We need to minimize the barriers to build algorithms that are reliable and fair. And we need to have tools that help us ensure that AI is responsibly deployed and it does not pose ethical risks through risk management strategies. And we really need to have an engagement of all stakeholders and not roll AI top down. So with that, I look forward to the discussion with the panel.
Thank you so much, Dr. Youssef. At this point, we are going to transition to our panel discussion. I'd like to ask my peer support to tech support to please spotlight all 4 panelists. If you have any questions from audience, if you have any questions, please add them to the Q&A box and like or upvote questions that you would like to hear answered. I will start off the discussion with a question that Dr. Youssef just mentioned, and it relates to public trust. But how can we build public trust for AI in healthcare? What strategies can be used to make AI solution more transparent and understandable to both patients, communities, and healthcare providers? And feel free to unmute yourself and answer the question.
Happy to get started on it.
All right, thank you.
I think there is, it's important to recognize it needs to happen at different levels and with different strategies. So you need transparency at the regulation level. The public need to see that the regulation for AI is robust, rigorous, and it really protects them against medical AI harm. So we talked about industrial components and how it's entering the market. We need to show that we're really doing our due diligence to ensure that any devices that are being rolled into clinical care is actually safe for patient use and effective. The second component is we need to build transparency. So you can almost think about it at the public level, and then there is at the macro level of the organizations of how actually organizations that are rolling AI are being transparent about the process of how they selected algorithms, why certain algorithms are being rolled into clinical workflows, and how and what is the benefit to the clinical and health profession care teams who are going to be using those algorithms. The third component, which is the most complicated aspect of trust building, is we need to recognize that there is patients who have negative experiences in healthcare, and we need to have strategies into how we really be proactive in care delivery and really start working towards building trust. And that requires a really, like dedicated effort of really showing patient-centered care of the physician really understanding the patient needs and really kind of collecting and making sure that we have, understand the disparities that drive health outcomes. So these are 3 things that come to mind when we think of how we can approach public trust.
Thank you.
I'd love to add something to that, if that's okay.
Yes, of course.
I think the trust part of it is a key component. So of course there's a privacy part of it and autonomy part of it. But I think one of the things patients are looking at is now, do you trust your provider to give you data that is correct for you or reflective of what your ethnicity or cultural background would have? And I, again, go back to, there's a reason I'm using the Framingham study. That's the biggest cardiac risk factor study. That's where all the things that came from, like, what's your cholesterol be at? What's your risk for heart attack? What's your risk of stroke? With cardiac mortality being one of the highest reasons for mortality in the US, it is data that we use day in and day out. But if you peel back, the study was done almost 75 years ago. Actually, they just celebrated, last year, they celebrated their 75th anniversary. It was done out of a small area out in Massachusetts, Framingham, Massachusetts, which is why it's called Framingham. And was 5,000 initial population, and they've followed that population for 3 generations now. But if you think about the studies that were done 75 years ago, right? If you think about the ethnicity of people out in Framingham, Massachusetts, it's going to be very different from the ethnicity out in Northern California. Now, if I'm using those results to apply broadly across all ethnicity and all population, there are patients who now are really smart because, we have the internet, saying this doesn't quite apply to me. And I bring this up again because 50% of South Asians will have a heart attack by the age of 50, but that's not reflected in the Framingham study. Diseases, carotid disease. The papers published that it's different in African Americans versus the Framingham study. And this is just one such study, even things like osteoarthritis, which is really common, and we use it to gauge the pain in patients. The pain that African Americans feel is very different from what Caucasians feel. Yet the modeling is done based on a certain ethnicity. And so patients are now getting really smart. And that's where the trust issue comes up, saying, if you're using a study that was done 75 years ago, how do I know that it's still applicable to this population? So as healthcare providers or as people involved in healthcare, our job is now to update these models and these studies that are more representative of the patient population we're treating.
Thank you.
So I don't know, Irene, if you have comments, but I just wanted to follow up that I totally agree with Nisha about the importance of updating these studies, but it's also important to recognize that there has been positive examples of how this has been, of efforts to try to improve that through the all of us data sets, through the precision medicine, where they're looking at building new cardiovascular databases that brings in data across the whole nation and allow for open data access for people to conduct cardiovascular research, brain research, and other forms of research that use really representative data. So I think it's important to recognize and appreciate the positive examples and ask for more of these initiatives to be there and support that, as well as to recognize that we definitely need to just do a lot of efforts in terms of thinking about the studies, but we also need to think about the studies in a very different way, where we cannot no longer only think of randomized control trial or prospective trial to see whether the AI is safe or not. We will need a subsequent set of trials and actually seeing how AI affect patient outcomes. We have not realized in any of the AI that have been developed or even implemented how they really impact patient outcomes on the positive term. So I think this is the North Star, but we are far ahead. And so we need to track back and really look at how can we work in step by step in building the research pipeline and to ensure we achieve there.
Yeah, I was struck by, so one interesting statistic, 1 year ago in February 2023, Pew Research did a study where they asked Americans, would you feel comfortable? How would you feel if your doctor were using AI to treat you? And so in a result that surprised me a little bit, because I think about this all day long, 60% of Americans said that they would be uncomfortable if their clinician used AI. And I think part of that comes from the fact that oftentimes AI is presented to clinicians as something that clinicians do. It's a tool. It's better than what they have now. It's going to save them time. It's going to save the hospital money. And that is the main motivator for using these more and more advanced models, these larger and larger data sets. What I would like to challenge everyone to think about is how, as we have this paradigm shifting technology, how we could use it to benefit people who have already been underserved. And it's not about consolidating, doctors' times, although it could be very useful and although it could help catch mistakes, et cetera. There are a lot of different possibilities. We don't have to just redo what humans do really well now. Is there a way that we could use AI and humans together in a way that is therefore more trustworthy, which I think is the original question, but also allows for easier prototyping, giving feedback in a more consistent way, and also determining when and not an AI would be helpful. So I think expanding our idea of when a patient should be working with an AI or a nurse or other community health advocates who could be able to leverage some of that. I think that is a huge flaw of the way that we currently think about health and health AI.
Thank you, Dr. Chen. I do have a question from the audience that is referencing the Framingham study. Along the lines of the point made about the Framingham heart study, decades old, non-diverse population, I'm interested to hear the panelists' views on how AI can help address the severe lack of research on women's health issues. Maybe it won't be through large language models, since there likely isn't data available for it, thankfully. Isn't it time that the medical community stopped saying we don't know for most women's health issues. For instance, statins aren't great for all women, especially Asian women. Reproductive health is a whole other topic.
I'm happy to take a pass on that. I take a stab at that one to start with. You're absolutely right. There is limited data, and especially large study data on women's health. There's also, it's not that the information is not available. There is information available, but part of it is the intensity of research in that reproductive health population, especially, and that's our own fault. I'm not, somehow we seem to be more interested in studying the effects of cirrhosis than reproductive health, right? And you'd think reproductive health being 50% of the population, you just from a sheer number perspective would be something that we would want to deal in. I don't have a good answer to it, besides the fact that I think as people realize that reproductive health is not something that's made up in a woman's head, and realize that there are actual consequences to some of these issues. There is an intensity that is developing. So I am hoping in the next 10 or 20 years. So for example, pelvic pain, for the longest time, pelvic pain's been blown off. Patients have gone to psychiatrists, patients have gone through this is hysteria, but now it is recognized that this is an actual disease state and that this needs to be addressed and needs to be taken care of. So I would say that there is hope. Maybe I'm being premature in my hope, but I think there is definitely more traction getting the female population studied better.
Thank you. Anybody else?
I mean, I'll second the point that there is so much we don't know about women's health. There's research that says that the menstrual cycle, where you are in your menstrual cycle, can affect many of your measurements, your lab measurements, and we often don't even track where people are in their menstrual cycle. We focus a lot on reproductive health, which is quite important, but we don't focus at all about sex differences on disease presentation. And in fact, we often have the assumption of default male in the data that we collect. From a machine learning perspective, I sit and look at data sets all day and machine learning models. A lot of that comes from the observational data sets that we have collected through electronic health records. And now we're getting more creative as well and thinking about how we could start to leverage these data sets for better insights, or how we could be out there collecting even better data. So some of the efforts that I'm very excited about are that different people are starting to create essentially disease registries, but focused around many different things. So they're volunteering their data. They're saying, here is my Fitbit data. I hope that is helpful for understanding how these different conditions might affect people over time, thinking about different ambient data sets that we could collect as well. This, of course, raises privacy questions, which is maybe a whole other question that we're about to be asked. But I largely support bringing more people to the table. And I mean that both within the data set that is being collected, more people being represented, more people being recorded, to be honest, but also more people into the workforce. Research shows that underrepresented both genders and also minorities study topics that are overlooked by the majority of the workforce. Just in healthcare alone, in healthcare and AI alone, there's a great researcher at Columbia, Dr. Noemi El-Haddad, and her personal experience in endometriosis has led her to focus her entire research lab towards that goal. And then likewise, my own research looking at machine learning for risk stratification of domestic violence comes out of a personal interest, which we would argue is not one of the canonical questions and the canonical topics in AI for health. And so I think the more that we can get a broader range of people excited by and and educated to better deploy AI tools, better evaluate and develop these tools, then we will be able to start address a wider range of problems, including women's health.
And I don't want to hog the conversation because Nikki's not had a chance to speak, so I'm gonna shut up in a couple of seconds. But I do want to highlight one thing, is that researchers often also relate in somehow, some weird manner, a reflection of where our political politics are, if you will. And especially for women, for example, lots of women have just completely deleted their reproductive history or menstrual history from anything that could be used to collect larger data, right? Like my daughter, for example, I can't remember what program she used, but was worried that people would start tracking her menstrual history. This is living in Northern California, right? I mean, in a very, very inclusive neighborhood. But again, there's a fear. So my biggest worry, the counterpart to what I said, is there's more research being done. My biggest fear is that we will come to a standstill in data collection as privacy issues become forefront due to politics of the area, if that makes sense, right? I completely understand people will value their privacy because of what they think the government could do with it, but that also affects research because now you stop collecting data, if that makes sense. Sorry, Nikki, and I just, like I said, I will now for the next few minutes.
Oh, good. And just to say a word, I mean, women's health is not my specific area within anesthesia, but I would say that, it's historically underfunded, and that is no accident. That sort of reflects the disparities that exist currently with regards to like attitudes towards women. Also within, medical education, you look at some hospitals, some large hospitals have, maybe five or six OB-GYN residents, per class that are serving entire like communities. And so that's also a big problem. And that also creates a drain on like what resources and like, human resources and, academic resources are available to research these issues. But as Irene mentioned, I do think with the advent of the EMR and the growing availability of data, that hopefully, we can start to prioritize women's health issues, and big data, will hopefully help to do that. Again, there's issues with the quality of the data we're getting from the EMR and the types of data we're getting, whether it's narrative data or like, or an unstructured data versus more structured data, and even bias surrounding data entry. Is it being entered at some of the panels by the patients themselves or by the clinicians? So these are all issues that are going to come to the forefront, I think, in the coming years as we continue with more of these studies looking at big data in women's health.
And because I will add one last sentence, which is really important, because this really hits on a very important point of historical fact that in many therapeutic and drug intervention trials, women and maternal women specifically are excluded. Pregnant women are excluded from trials because of the unknown risks of the trial and the ethical principle of doing no harm. The main question as this kind of a research paradigm down trickle or downstream to AI interventions is AI will be deployed in hospitals, and we really have no information on how AI tools will affect patients and pregnant women. And so I think it's important to understand the ethical and support, like the regulation of medical devices to include these populations in order to ensure that the safety of the devices are applicable to these patient population. And I don't think like it is acceptable that, we have devices that would be available to some populations, and some populations, because they were not involved in the data collection, or the drug has not been, or sorry, the AI has not been designed to really help with diagnosis or care, that they are excluded from, from that, because that goes against the health equity component. So I think there are important ethical and research conduct principles that we need to revisit to inform, and improve AI research in maternal and women health.
Thank you, everybody. The next question, I will combine my own question to one of the audience questions. How can we make sure that AI and machine learning tools do not perpetuate existing biases in healthcare? And this, related to this, is an audience question. I'm very interested in learning about the practical actions that you and your labs or groups, organizations have taken to minimize threats to health equity. Could you share strategies you have adopted to ensure equity in your current work in any steps of the algorithm, from training data sets to full implementation?
I have an example to share, but Erin, I think this is your area, so I wanted to give you the platform.
Yeah. So I think one of the ways that I like to think about it is the fact that there's a lot of different ways that equity and bias can be examined. So you can think of it in a few different stages. One is that the healthcare system as it currently exists is biased. So one example of a project that my lab is working on here is that we could look at clinical notes and we could use machine learning to determine when the clinicians are writing notes that might include stigmatizing language. And so better understanding the existing biased clinical practices now is sort of one bucket of figuring out how we can use AI to improve clinician bias. Then there's another bucket, which is that the algorithms, as they get developed, might introduce more bias. And so that becomes a question of how do we combine data sets? Are you actually drawing from, oh, this large data set collected in Boston that is not at all applicable to your rural population with a very different demographic? And so understanding how that machine learning development process can be skewed. And then there's, and the algorithm development process itself might be adding bias and figuring out how we can set up algorithms in that way is sort of a second bucket. So this is what we would call like algorithmic bias probably. And then the third bucket is actually once we have a model, even if the model seems to be fine, what is the downstream impact into the clinical system? So even if the model is doing exactly what you told it to do, it's not deviating, it's not going rogue, maybe you're putting an additional load onto, say, the radiologists who are now being flagged as saying this person should go see a radiologist because the threshold was set incorrectly and there are too many false positives. Does that lead some people to have to spend more on getting radiology scans, stay more time in the hospital, which is an infection risk, take more time off of work? Sort of like, what are the equity implications of the AI tools that we use? Who trusts them? How does it really mess up someone's day and or the entire healthcare system? And so I would say thinking really critically about how AI can be useful or not useful for each of these three buckets or ways that we think about AI, I think is an important framework for me, and I hope for other people, about separating out, does it help or does it hurt?
So I have a couple of examples from my research at Amy Center. So one is in radiology, where we recognize that actually the way radiologists label them, so let's say we have fair data sets, the way clinicians label, because clinicians have implicit and subjective bias based on their training and level of expertise, the way they draw even the bounding boxes and labels that we give it to machine learning can differ. And so if we're not attentive to, actually addressing the bias in labeling, we can reproduce some of that bias or introduce that bias into the machine learning algorithm. So also being, like promoting reflective awareness and kind of like the practice of AI and ML is what turned to be very important. I think the other component where really organization-wise and practically has been taking strategies to kind of ensure the AI that being implemented is safe is the Stanford Healthcare with the data science team led by Nigam Shah and Nikesh Kotesh at Stanford Healthcare, where they run a process called FAIR, fair, reusable, responsible, and measurable. And the main components of this process composes a number of teams. We study the population, we conduct ethical and policy regulation assessment throughout the solution. We introduce stakeholders who are developers, clinicians, people affected in the workflow to understand the impact of that. And we also do utility and impact assessment to see how this can actually impact workflow. You cannot just rule in, even if the algorithm is helpful, you cannot just throw in something into the workflow. You need to understand, does your FTs support and how many FTs you would need? Does that add additional cost? And so we find that there's a number of processes and safety measures that organizations really need to take in order to be able to really kind of have safeguards that ensure that AI is implemented responsibly. So I think this is one of the most practical things, but there's also other efforts similar to that in other institutions that are starting really to roll and think about it holistically, because we recognize it's, as Irene mentioned, it's really a pipeline. You really need to think of the different components of it.
So I would add a little bit to that in, and this is putting my clinician hat on, right, which is where I come from, is I don't think we're paying enough attention to the upstream or the data in, right? To me, the start is actually your patient, right? And one of the things I'm working on right now, for example, is when we are working with patients for whom English is not the first language, or using the patients who are immigrants and come from a culturally different place than most Americans, you will notice that the conversations are shorter. The patients themselves may be less willing to be part of clinical trials because of their cultural background or where they came from, where, you know, being a part of trial was almost like, well, no, I don't want you experimenting on me. So there are just these inherent distrusts in the system that, you know, if you put me in a trial and I'm going to become a guinea pig. So if you now take these patients who may have not quite understood what I'm saying is going through an interpreter, or may not be as willing, that patient population is getting excluded from any of these, the data in. And to me, it's garbage in, garbage out kind of thing, right? If I don't have an inclusive, diverse population going in, you could build the best AI model. You're still limited in your base population. And so I think some of the things I'm working on, for example, how do we not go through interpreters, ethically not go through interpreters? And I think this is where culture meets ethics in medicine, because legally speaking, in the US, the patient has to agree to the procedure. You only talk to the patient, you don't talk to the family. And then there are safeguards put in for a reason. You don't want family biasing what the patient should be done. Yet on one hand, yet on the other hand, we have patients who come from cultural areas where the decision's made as a family, not as an individual. And I think this is one of the hardest things that physicians are working through, is trying to make our care culturally appropriate, if that makes sense, right? It's like an Indian or a Middle Eastern or East Asian will have very different philosophies than, say, somebody from Northern Europe. And so I think that needs to, and so that is the data that we need to first work through before we start feeding it to the computer, because again, like I said, garbage in, garbage out.
Yep. And then just in terms of thinking about that question of how do we create tools that don't perpetuate existing biases in healthcare, I think Irene did such an awesome job of like highlighting all of the conceptual considerations, from data to like testing and validation to post-implementation concerns. I also think like an example is sometimes a really good way to think about this too. So not to rehash that, but to think about maybe an algorithm maybe we're trying to develop that is to diagnose melanoma. Okay. And we know historically there are disparities in melanoma diagnosis on the basis of race. There's plenty of data in the literature that shows, implicit bias leads to delays in diagnoses, and this can lead to worse outcomes down the road. So what does that mean in terms of like practically how we develop this model? So first off, that means having a balanced and representative data set. Okay. So that means having data from individuals of many different skin colors, many different backgrounds. And if you don't have access to that data, there's a lot of interesting emerging areas of research to, try and circumvent that. So things like collaborative learning strategies where you're training different models in parallel. And then also synthetic data generation, which is another, area of interest, still has its issues, but those are some data level considerations. And then when it comes to testing the model you've created and you're validating it, you want to be assessing, across these different skin types, am I having like the the outcome of interest depends on your intended use. So we want to know, like, what is our false, we don't want to have an increased rate of false negatives in darker skinned patients, right? Because that is essentially this disparity that we are going to, recreate. So we want to be assessing for that continually, in validation. And then after this algorithm is created in the post implementation phase, we also need to be assessing for this. So I think that's just, how I sometimes like to put things in perspective with a practical example. But I echo everything that the other panelists have said. I think these are all fantastic points.
Anybody else? So this is a fascinating and very informative conversation, but eventually we will run out of time. I will ask one last question, and again, it's kind of a combination of my question and one of the audience questions. So we are in a medical school here at Stanford. I'm sorry, I lost my question. Yes, got it. How can AI be integrated into medical education and training to promote cultural competency and sensitivity among upcoming healthcare professionals, as well as how do we educate healthcare profession students, especially nurses, who have so much face time with patients about AI and ethical considerations in practice?
I'm happy to get started on this one. So I think Stanford Medicine specifically there's a number of outstanding faculty who is leading work to integrate AI into horizontally across the pre-clerkship program into the curriculum. And I think it is being well thought on what type of courses and where it would be integrated and what are the competencies that medical students would need to fulfill to be competent in using AI. But I think one of the most important components to reflect on is we will not only need to think of the education, we will need to think of the mentorship and training, because it comes to clinic, it comes to showing clinicians and residents and letting them understand how they build their clinical skills, as well as what are the reflective tools that is actually the safety measure to make a decision whether to use an algorithm or not. And so I think promoting different set of skill sets in physicians and medical students would be very important. It will be important to have the bioinformatics information about how workflows work, how HRs work, how things are flowing, and where could things go wrong in order for them to be able to assess really in the situation. It's like, any medical scenario, they're being taught to assess the situation, and now that they're using algorithm, it's just should not be, just because it's in the workflow I would use, but it also would require, is this the right tool for me for this patient? And so I think that is a paradigm shift in how medical education and health profession education in general needs to be moving towards. And I think we're learning a lot of this in the work that's being conducted to evaluate algorithms at Stanford Healthcare, where we recognize that actually nurses interface with patients a lot in sepsis. They are the ones who are closest to patients. When should an algorithm notify a nurse versus a physician? Who should be the primary contact? And actually, one important theme that came through the research that was really fascinating is that there is already a lot of burnout and tension across clinical teams, the nurses and the physicians. And so the last thing is we want to insert an algorithm that will lead to increased false positive, that will actually make the environment or the culture team environment more hostile or, frustrated for them. So I think thinking of the culture component of what is the role of AI is really important to ensure that, the health profession team are really having a positive experience.
I would actually encourage people to have a degree of healthy skepticism into everything that we do, because medicine traditionally is a hierarchical model, and it's similar to, I would almost say it's similar to, not to the extreme of, the army, like the armed forces, but the general belief is if my attending says so, or if the doctor says so, it's got to be correct or it's got to be right. And I actually even tell my patients that, have a healthy skepticism of everything that I'm saying, because at the end of the day, I am a human, and the patient is the best advocate for their care. And the same thing goes with AI models, right? don't take everything at face value. So I actually teach my fellows, ask questions, because that's what leads to more discovery. That leads to understanding as to why things work and why don't things work. It gets a little harder with AI because, at least for me, I don't understand how some of these algorithms work. I'll be upfront about it. If somebody says, this is what you see on a chest x-ray and this is what it means, let's just say, for example, a chest volume that's less than, it's off by one standard deviation, it's going to mean that you're going to live 10 less years. I'm making this up, so this is not true. So don't, but I'm just saying, if somebody said that, I would want to understand what in that x-ray is making me say that. And unfortunately, with AI, we don't have that reasoning behind it. And you guys can correct me if I'm wrong, because you guys work with this, but there are times the things that are spat out by the model which don't necessarily make sense. And I'm not sure how we can address that. But a healthy dose of skepticism is always good for the human health.
Yeah, I completely. Oh, go ahead, Irene.
No, Nikki, I think you got the final word.
Okay, so I completely agree with you, Dr. Kathari. I think that, these AI tools are like any other drug or medication we give. We need to make sure these are validated and rigorously validated at that. And a lot of times these tools are piped directly into the electronic medical record, and that information isn't readily available. So I think that's a real issue. Some of them you're able to click in to get more information about like validation, but not everyone is doing that. And then with regards to not understanding how this model is working, how it's generating predictions, I think there is a lot of research on interpretability right now. Many more academic papers are starting to show like, okay, this is what the model is looking at for this particular input. This is why it gave this response. However, in terms of like clinical practice right now, I think these tools, like a lot of these tools, and Irene, you may correct me if I'm wrong, aren't there yet, like practically speaking, but we're moving towards that, and that is exciting. So I will say, I think we're going to get a better understanding of how this is working. But like with any tool, I totally agree. Very healthy sense of skepticism. And then Dr. Youssef, you were saying what you were saying, I just thought of an instance the other day when I was in the operating room. I was about to extubate a patient, and this best practice advisory came up, and it was telling me, consider screening your patient for diabetes based on their risk factors for diabetes. And I was like, what is this? Like, why? It's not relevant to me. It has nothing to do with as an anesthesiologist, I'm not the one screening patients for diabetes, and the timing was also inappropriate. And then it leads to burnout, it leads to mistrust on the part of physicians. And these are all, important things we should be thinking about when we're implementing these technologies.
Thank you. Dr. Chen, any final thoughts?
I think Nikki had it. Yeah, that's so great. Thank you so much, everyone. These are really interesting points.
Thank you, everybody.
Thank you,
so much.
everybody. So this was a fascinating and inspiring session. I would like to thank all of you for participating and sharing your wisdom and knowledge with us. At this point, we are going to take another 5-minute break so we can all stretch and refresh a little bit. On my watch, it's 11:03, so we will adjourn at 11:08 and with the closing keynote.
Thank you so much for the invitation.
Thank you. Thank you, everybody. Really appreciate you.
Oh, that's my biggest page.
Dr. Rizvi, can you hear and see us good?
Yes, I can.
Awesome, wonderful.
What about you? Can you hear me?
Yes, I can hear you clearly and see you.
Okay, great. And I will be sharing my screen for the slides.
You should be able to.
Okay, perfect.
Thank you.
Yeah, you're welcome.
Thank you. All right, so this quick break is up, and we are returning at this time to listen to the closing keynote address. I have the honor of introducing Dr. Rubina Rizvi. Dr. Rizvi is a physician informatist, yes, sorry about that, serving as an assistant professor in the Department of Surgery, and she is a digital innovation integration lead at the Center for Learning Health System Sciences at the University of Minnesota, Twin Cities campus. She has a career that is a blend of both international and US education and has over 10 years of experience in the field of health informatics, both in industry and in academia. Her expertise is in usability evaluations and workflow analysis, human-computer interaction, and qualitative mixed methods research around digital technologies in healthcare, including AI-based tools. Her goals are centered around the 5 rights framework, which is right information to the right person in the right intervention format through the right channel and at the right time, with special attention to the end user and the underserved populations. Her passion for serving humanity has successfully led her to key leadership positions, namely co-chairing the American Medical Informatics Association Diversity, Equity, and Inclusion Committee and Academy Health, a community of practice pilot. I will turn it over to Dr. Rizvi. The title of her closing keynote is Decoding Existing Gaps in the Adoption of Healthcare Technology by End Users. What, why, and how? Please welcome Dr. Rizvi.
Thank you very much, Boglarka, for your warm introduction. I feel honored and thrilled to be here. Can I just go ahead and share my screen?
Yes, you should be able to share screen.
I will pull up my slides.
Yes, we can see it.
Is it okay if I do the presenter view, or how do
Yes.
you? Okay.
Or you can do, yes, presentation mode. We can see your notes this way, so.
Okay, so is there a way? I'm not sure what would be the best way to.
Do you
that I
have
can
2
see my notes?
screens?
Yes, I do.
Try to share the other screen, the one that has the presentation only and not your notes. Like if you stop sharing this screen and share the one that has the full size presentation slide.
Okay, let me do that.
There you go. Perfect.
Can you see the full slide?
Yes, we can.
Okay, no, not my notes, right?
Not your notes, just the
Okay,
slide.
perfect, perfect. Sorry about that.
Oh, you're fine.
Yeah. So again, thank you so much for having me here. I'm thrilled and excited, and thank you for all the great talks, the opening talk and the panelist discussion. It was very interesting, and I learned a lot from that. And then, of course, I want to give a shout out to all my women colleagues, many of them being moms, who all are proficient and skilled individuals who balance multiple roles with great finesse, perseverance, and dedication. So thank you. So topic of my today's talk is decoding existing gaps in adoption of healthcare technology in general, and that includes AI-based technologies by end users. And it does align very well with Dr. Eileen Koski's talk and some of the topics which our panelists touch. And I would add one more thing. I have worked at IBM for several years in the Center for Artificial Intelligence Research Evaluation. So I have some experience evaluating the AI products owned by IBM. So yeah, and it was a great experience. I have no conflicts to declare. Digital technology referred to using advanced advanced technologies that render sustainable value to patients, healthcare professionals, and healthcare organizations. It has advanced more rapidly than any innovation in our history and impacted various industries that includes retail, manufacturing, banking, education, and of course, healthcare. So this accelerated advancement of digital technology, including the AI-based technology, has a huge impact in healthcare industries. New technologies getting introduced at a rapid rate to various end users, clinicians, and patients. Does the click button work? I cannot see the other screen, Boglarka.
Yes, yes, it does. It should.
Okay. So the question arises, are we successful in such digital transformations? And the fact is 70% of complex large-scale transformations are unable to meet their goals. So emphasizing the notion that digital transformation is a journey needing strategic planning.
There may be a move forward button on the bottom right of your screen. Can you see a button down there? Just to move to the next slide.
I can't.
Yes, there is on the very bottom to the left, there's a
To the left?
little gray arrow to the left. On the very bottom.
Is it this? Did it work?
Yes, it's working now. Yes, it's moving.
Okay. All right. Sorry for this technical.
No, you're good.
Like end users error, I should say.
Right.
Yes, right. So this slide is based on a commentary article published in New England Journal of Medicine, Catalyst, and it's by Dr. Stanley Shaw from Harvard School of Medicine. And he discussed the three main areas of foci for a successful digital transformation. Number one, defining the transformation before choosing the appropriate technologies rather than allowing technologies to dictate the transformation. Number two, innovating the business model to take advantage of new capabilities. And number three, managing the process of organizational change. In the next few slides, I will talk about some commonly seen benefits and barriers of digital transformation. And I will highlight a few of the bullet points where my work is centered around, and I will describe those in much detail in later slides. So I will give you a few seconds to go over this list. I don't want to read it, but I would really like to highlight the bullets or the areas where my work is focused. So that's patient satisfaction under patient and provider bucket, optimization of workflow, that's under healthcare institutes and organizational bucket, then better patient experience, and lastly, accessible and equitable healthcare to all. Here's a slide showing, this is not an exhaustive list, but some of the common barriers that hindering with digital transformation. Again, I will give you a few seconds to read, and I will highlight those which are important to or relevant to my work. A suboptimal strategy to leverage technology in an integrated way, employee pushback and resistance to change, suboptimal design and poor user experience, technology skills of individuals, training and education, and fragmented consumer engagement experiences. And then, of course, I have more of the barriers listed here. But as I said, this is not an exhaustive list. There are many others. I will go to the next slide. Keeping in context the importance of digital technologies, their benefits and associated barrier, a framework for digital health equity incorporating key determinants of digital health was developed. Such a framework is much needed to support the work of leaders and developers in the industries, health system operations, and academia. The Framework for Digital Health Equity is an expansion of the National Institute of Minority Health and Health Disparity Research Network. So this is the framework. I took the screenshot from the Richardson et al. Paper, and several of my slides are based on their work. So the framework is organized into 6 domains and 4 levels of influence, directly or indirectly impacting the digital environment. So the domains are biological, behavioral, physical, social, cultural, healthcare system, and then the 4 levels of influences, which I will be talking about more in detail, are the individual influences, interpersonal processes, community level processes, and societal involvement. In the next few slides, I will talk about the 4 levels of influence in respect to the digital environment domain. So that's I highlighted this this section. Starting with individual level determinants, which is my area of research, one of my areas of research, and there are several individual factors that could impact technology adoption and its sustained use. So some of the common ones to list are health literacy. So that is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Then comes digital literacy and digital self-efficacy. So digital literacy refers to skills and ability necessary for digital access, including an understanding of the language, hardware, and software. Whereas digital self-efficacy is an individual's self-efficacy with regard to the effective and effortless utilization of information technology, and it predicts proficiency. Then comes the attitudes, which again, a lot of my studies are focused on the attitudes, and then the next bullet, ease of use, usefulness, usability, and satisfaction. So these are the 2 key areas where most of the work is, I've done so far. And then, of course, demographics is one of the most critical area, which has a huge impact on how end users are using the technology. That is includes age, gender, race and ethnicity, and socioeconomic conditions. The next level of the influence is the interpersonal level determinants. These determinants describe relational factors that connect individuals to both digital health technologies and one another. So I'm sure there are clinicians attending this virtual conference. So something for them to note down is the implicit tech bias. So clinicians may have been attempting to select patients more likely to successfully use the portal. However, implicit bias would have played a role in this assessment and may have contributed to unequal access. So what it means is patient communicating with some of the patients about the technology and how to use it, or introducing them to technology, and ignoring or a certain population. So that has a big impact on use and adoption by the end users. Then there is a communication gaps, of course, whether it's by clinicians or technology staff or whoever is helping patients or clinicians with adopting the technology. Interdependence is used to describe the dependence of 2 or more people, for example, family members, caregivers, or friends on each other for the digital skills, access, and equipment. So they share the equipment. And I give my examples. For my mom, I manage her healthcare records to my patient portal. So it's because she is not tech savvy. So there's interdependence there. And then, of course, suboptimal training and education is one of big issues, I should say, if not the biggest. And we need some, we need to address that. Then comes the community level determinants. So what's community level determinants include community infrastructure. That includes cellular, wireless, and broadband access, especially in the rural areas. And of course, quality and affordability of having the smartphones or devices. Broadband access is considered as an important health determinant. And I'm sure you must all be aware about the digital redlining that impacts the access. Then comes the healthcare infrastructure that includes community access to health systems with advanced digital capabilities, including sophisticated EHR systems, patient portals, and telehealth tools like remote patient monitoring and simultaneous audiovisual visits. Thirdly, community partners are an important contribution to the local digital equity ecosystem, the socio-technological system that works to increase access and includes technology advocacy groups, community health workers, libraries and librarians, and digital literacy training program at community level. Lastly, this is the societal level determines that includes more higher level, factors such as tech policies that includes the federal, state, and local policies supporting healthcare technology adoption by influencing its implementation, dissemination, and access. Then comes the data standards that are created and maintained by professional organizations. For example, Health Level 7 International, HL7 standards. Then social norms and ideologies are the set of beliefs and philosophies that impact who develops digital tool and how it's developed. Algorithmic bias, which we discuss in the panelist section, that has a huge impact as well. Then limited federal assistance to access critically needed smartphones, and the shortcomings of the Lifeline programs, which provides low-income individuals with discounts and other services. So I will give you an example of one of my ongoing work where which is grounded on this digital health equity framework. So this is a K grant which I received. It's a P30P CORI grant. And I am the project is about understanding utilization, identifying gaps, and testing new strategies to enhance patient adoption of patient portals from a health equity lens. So here, of course, and as everybody, especially the clinicians, they know what's the benefits of patient portal use and how COVID-19 pandemic has resulted in a substantial increase in patient portal use. However, the gap has increased, like among the different socioeconomic groups who are using the patient portals. Then growth in the use of technology has deepened this widening digital divide among diverse vulnerable populations. So through this project, I am planning to look at the existing data about patient portal utilization, both at the state level, that's Minnesota, and at the national level. And I'm in conversation with EPIC MyChart team folks, and we are trying to figure out what would be the best way to pull that data. Then I would like to reach out to patients and their caregivers from different cohort, like populations, to learn their unique challenges or barriers which is hindering with their adoption and use of patient portal. And then based on these two learning, I want to design some strategies along with the physicians. What I mean is having, along with the physicians and the patients, what it means is having them as research partners, not study participants. So they will have an equal say in the study design, data analysis, and even in dissemination. So getting input directly from the end users who are actually going to be impacted by this project or study. Now I've talked about the digital platform that includes elements of the physical build, understanding the content and logic, and as well as the habits and behaviors that dictate how we use this tool. I'm glad Dr. Eileen Koski also brought this area in her talk, especially the tool explainability. So there are three main areas. First one, the tool usability, is a quality attribute that assesses how easy user interface are to use. That includes 5 elements like learnability, efficiency, memorability, error prevention, and satisfaction. Then tool explainability, which is extremely important, especially when it comes to AI. Explainable artificial intelligence is a set of processes and methods that allows human users to comprehend and trust the results and output created by machine learning algorithms. And then lastly, integration with workflows, which is often neglected. So ensuring streamlined integration of technology in the intended clinical workflow, and that is especially true for physicians, to ensure that the least amount of disruption for providers and there's easy and sustained use. I will share another example or a use case study which we recently presented in American Surgical Congress, and it's under review in a peer-reviewed journal. So we did a usability evaluation of a clinical decision support system for traumatic brain injury patients to prevent thromboembolism, which is common among traumatic brain injury patients. So what I want to show you or share with you is how we evaluated at the 3 levels. I mean, the tool usability, tool explainability, and then integration with workflow, and what we found. So tool usability, what we did, we approached, or we did the usability evaluation leveraging 2 methods. One is the expert-based method. I won't go in detail, but it's called heuristic evaluations, where experts who are subject matter experts, they go over the interface and find or identify issues which they feel are going to be problematic. So that's coming from an expert's perspective. And then we did a usability evaluation or usability testing with the trauma providers. And we created simulated patients and a simulated test environment where they went over the patient certain scenarios. And the TBI CDSS, that's traumatic brain injury clinical decision support, was integrated, and it showed up at the appropriate time, and we collected feedback directly from the end users. So in terms of tool usability, we found several issues, which of course we conveyed to the IT team, and they address those, and I would say the tool has improved. It's not optimal yet, but it's an iterative process. So we found some like issues with redundant data entry, cumbersome navigation, some issues with some of the users pointed out, the font size, color related issues. So that comes under the usability bucket. Tool explainability was a huge, or very common, response or feedback that we got from clinicians. They wanted to know how the logic works and wanted to have the actual evidence there in the CDS embedded there, which they can look and are more comfortable in making the decision. So, which is not currently existing in the tool, but again, we are working on it, and we plan to have actual logic model like a PDF in the CDS. So and also the evidence-based, all the papers or the guidelines available through the CDS, so that if a clinician wants to go in the detail, they can click and actually read it. And lastly, integration and workflow changes. So one example was there were some interrupting alerts, and there were some non-interrupting alerts. And we got some feedbacks that how can we make some of the interrupting alerts non-interrupting so it doesn't interfere with a physician's workflow. So again, this is all this effort, I think, and I hope has resulted in a better tool which aligns with end users' needs and workflow, and fits better in their workflow. And in my introduction, as Boglarka mentioned about the 5 rights framework, so I'm a big supporter of this approach. I found 5 rights framework is extremely useful model when it comes to technology adoption, not just clinical decision support intervention. This is a well-known framework that's used to plan, assess, and deploy clinical decision support intervention. But I personally feel, and from my experience, this is true for any technology. This 5 right framework was developed by Osherf et al. So we have the citation right there at the bottom. And the 5 rights are the right information to the right person in the right format, through the right channel, and at the right time in the workflow. So how can we achieve that 5 rights goal? I'm not sure how many of you are familiar with the user-centered design approach. So the visual, it kind of explains we have users in the centers, whether they are patients or clinicians, nurses, physicians, and this is the system development life cycle. And we have 5 phases. The focus are the users. And so what it means is we would like to have ideally users involved in every phase of system development lifecycle, which is often not the case. So the goal is the final product should suit the user rather than making the user suit the product. So that means, again, users should be taken into consideration during each stage of design and development. And that's something what we are promoting at our Center of Learning Health Systems among the IT developers to ensure that we get patients and clinicians' feedback where needed in an iterative manner. I briefly touched about the usability evaluation method. So this is just a brief overview. So there are different approaches of usability evaluation methods. I have primarily used the expert-based heuristic evaluations and a user-based, that is the end user testing, which could be ethnographic studies, like going and observing them, usability testing in a simulated environment, and then, of course, surveying, interviewing the end users and learning about their experience. Again, I will share a couple of my examples. This is my work from IBM. So we evaluated the usability of a care management tool. And we talked to not only end users, but also the leaders to learn about their impression or their perception about the usability of the care management system. And of course, whatever we learned, we shared that information with the IT folks at IBM, and they were able to incorporate some of the recommendations or suggestions that were coming from the end users. This is another example of my work, which is, in fact, is pretty old. It's from my PhD thesis. So I looked at the usability evaluation of EHR, clinical notes interface from both residents and attendings perspective. So this was an ethnographic study. The first study was ethnographic, and then I did some usability testing using eye tracking, like in a simulated lab. And again, I compared two of the EHRs that's commonly used here at MPhil Fairview and VA Hospital, and found how, what are the benefits or what are the strengths and weaknesses of each EHR, and we kind of identified number of interesting areas. So if you are interested, you can Google it and find this paper. So in the end, the take-home message is digital health equity and transformation necessitates a multi-level understanding of how policy, systems, community, individual, and intervention factors interact. And it needs a collaborative work among practitioners and researchers. This could be achieved through, number one, co-design and iterative testing with end users. So that is something, again, as I mentioned, I plan to use this approach in my study through patient and family-centered research approach, where patients would be the research partners. Secondly, provide individual level support or training to people with different skill set, like customized training for patients. They are, I know at some places they are using digital navigators, like people going over a tool or an interface with the patients to ensure that they understand how to install it, how to use the common functions. So which is something I feel is going to make a huge impact. Then effective communication that entails open dialogue among clinicians, leaders, staff, patient, and their caregivers. And then leverage community and social partnerships to facilitate with widespread use of technologies. And that includes easy access to internet through maybe community buildings or libraries, or having a community advocacy group. So that could make a difference there. And then lastly, but very importantly, adopt policies, programs that would address barriers to digital health use. So this is the end of my presentation. Thank you very much for your time and attention. So yeah, please feel free if you want to know more about my work or have any questions. My email is right there. And thank you.
Thank you so much, Dr. Rizvi, for closing out our conference today with such insightful, interesting, and timely research, especially from the end user perspective. This was very interesting. I really appreciate your time and sharing your wisdom. And with that, we are coming to the end of today's program. I would like to take a moment and thank all of our panelists and speakers for their time and effort. Personally, I feel very inspired after hearing the career journeys and research efforts for all the women who spoke during today's conference in relation to our theme, which was artificial intelligence and health equity. We appreciate you all sharing your expertise and making this event a success. And I would also like to thank the team at Lane Medical Library here at Stanford University, because without them, this event would not be possible. I will go ahead and quickly share our there is a link